Now let's talk about asystole. It may seem silly to spend much time on this, but I do have a couple of things I want to point out. First of all, the heart has lost all of its coordinated electrical activity. You may see actual variation in the waveform, but there's nothing there that we can actually call a P wave or QRS or even fibrillation that is according to our definitions. There may be a little bit of residual cell-to-cell communication, but really no coordinated effort. And you do not have any of your pacemakers, no atrial pacemakers, no junctional pacemakers, no ventricular pacemakers that are functional at this time. So when we go through our diagnosis or determination, all of our questions of regularity, rate, P waves, PR intervals, QRS complexes, the answer is going to be no or zero. For these patients, their symptoms, if they are in asystole, they are pulseless. You should not be able to palpate a pulse. They should be fully unconscious and they do not breathe. They may have an agonal respiration every once in a while that's reflexive of some leftover neurologic activity, but really nothing is there. If you go in the room and the patient is awake or responds to things or is breathing heavily, check your leads. It is possible in some leads that if a connection point becomes dislodged or stuck to the gown or the bed or something like that, you may get a reading of asystole. No matter what, when you see this rhythm on the monitor, please go check the patient. If you're in the monitor room, you need to make contact with the staff very, very quickly. Treatment for this is, of course, to call our 6444 and notify the operator of the cardiac arrest. Start high quality CPR. This is our opportunity housewide to improve that. Yes, we need to get that CPR started and make sure that it is high quality. Or if the patient is on comfort care, make sure that there are measures in place for the family to support them. If you are doing virtually, we do have the ability to connect families via iPads, or if they're in person, our chaplains are very willing to come and visit with the family and support them in the passing of their loved one. If we are doing resuscitative efforts, ACLS has just the epinephrine and then going through the H's and T's trying to figure out what caused it along with that high quality CPR. It is very difficult to bring someone back from no rhythm to a perfusing rhythm. So let's just practice. Here's a couple little funnies. Yes, both of these are asystole. Notice, yes, there's a little bit movement in that line, but really nothing you can call a QRS complex or a P wave. And I just want to call out that no one goes asystole in the hospital like the movies. So you don't go from a complex that you can call something. And I don't know what movie director created that complex. I don't even know what that is, but to an absolutely straight, no movement line. That's just not how it happens. So that is asystole.